Good morning, everyone. We are going to be covering the chapter on vascular disorders. That's chapter 37. If you want to pull it up and follow along. This is going to cover venous and arterial disorders. So we're going to start the first half of this with arterial disorders, starting with peripheral arterial disease, or PAD. The leading cause of PAD is atherosclerosis. So just like when we were talking about earlier in our cardiac section with the heart, atherosclerosis can occur in the peripheral vessels as well, in the peripheral arteries. So risk factors for this are smoking, history of hyperlipidemia, elevated C-reactive protein, or that enzyme that is elevated in situations of inflammation, which would be occurring in these vessels where the atherosclerosis is building up, diabetes, high blood pressure, and a family history of PAD. The pathophysiology of PAD is related to the progressive nature of atherosclerosis. So same kind of thing that was happening in the coronary arteries with the development of atherosclerosis is happening in these peripheral arteries. Damage occurs over time. The body attempts to compensate by developing collateral arterioles. Again, thinking back to that slide where the heart had developed collateral circulation, the peripheral circulation will do the same, but that takes time. It develops slowly and progressively with age. The body will also attempt to compensate by vasodilating, but then the body is unable to meet oxygen demands to the peripheral circulation that way. And then anaerobic metabolism will occur because we don't have enough oxygen. So instead of aerobic, which makes much more ATP and energy for our muscles and organs to use, we're without oxygen, so we're going to be using anaerobic metabolism. That makes much less energy, and then lactic acid will build up within our muscles and our vessels, and that can be painful to the body, actually. Just like when your muscles are working out, and in a good way, you're kind of sore after you work out for the first time because you're using muscles you haven't used. You're going to disrupt your oxygen supply and demand early because your body's not used to working out, and as you're getting into shape, that'll start going away because your body will start compensating for that, for those oxygen demands. Well, here we're not getting to that point, so they're just in this state of that lactic acid continuously building up. And then this will all result in stenosis and ischemia within those blood vessels. So pain will result from the lack of blood flow, the lactic acid buildup, and the decreased perfusion to the extremities. Our signs and symptoms are related to those pathophysiological changes. So a term called intermittent claudication is just a term we use for sharp cramping or burning pain that's related to the ischemia and the lactic acid buildup. It feels like the hip or leg is going to give out. Pain with exercise or activity that may be relieved with rest. So in those moments where we're working hard and our vessels are vasoconstricting, so those areas of atherosclerosis are coming together and obstructing that vessel even further to provide blood flow. So by resting and allowing those vessels to relax and dilate out can relieve that pain. This is associated with coronary artery disease. They go hand in hand because the same kind of patho is happening. And then these, for the same reasons that diabetic patients need to check their feet daily, these peripheral artery disease patients need to check their feet daily because in diabetes, they develop neuropathy from the increased glucose in their blood that causes it to become thick and viscous and syrupy and decrease perfusion. The same thing's happening, but for a different reason. Instead of the increased blood glucose buildup, there is a buildup of the atherosclerosis, which is decreasing the blood flow to those areas, which over time can decrease the perfusion to those nerves and cause a neuropathy to develop. Further along in the progression of PAD, pain can start to occur at rest. It is common at night. The pain is described as dull and deep within the toes and feet, or as paresthesias, as pins and needles. So we're getting more into that nerve type pain, that neuropathy pain that can be very hard and non-traditional to treat. Further clinical manifestations are decreased pulses. When we are finding it difficult to palpate pulses, then we measure them by Dopplering the pulse. But we do want to, instead of just assuming that there's not a pulse there, we do have to back it up with a Doppler to try to find it. These are signs and symptoms in the legs themselves, and you need to know the difference between these signs and symptoms in PAD, and then later on when we talk about PVD or peripheral venous disease, you need to know the difference between the two symptoms of PAD and PVD, arterial versus venous disease. So in arterial disease, we see dependent rubor or redness or reactive hyperemia when their legs are hanging in the dependent position. Pallor with elevation, so as they're elevated, their legs become pale because the arteries aren't able to kind of perfuse past gravity to get up and perfuse the legs. The skin is cool, hairless, and mottled with pinker purple blotches. And then there's delayed wound healing in both peripheral artery disease and peripheral venous disease. Arterial ulcers are less common than venous, but they're small, round, and well-defined. In venous disorders, they have more of some irregular borders. And this is the difference here. In picture 1, this would be an arterial ulcer. In picture 2, this would be a venous ulcer. What are we going to do to treat and prevent peripheral artery disease complications? Well, first of all, weight reduction, exercise, smoking cessation, good diet, reducing lipid levels. How do we do that? We promote a healthy DASH diet, decreased saturated fats, decreased triglycerides, and more fruits and vegetables and lean meats and whole grains within the diet. And then promote arterial flow. Those are with medications like vasodilators, antiplatelet medication like aspirin and Plavix, and then pentoxifillin or Trental is a medication that we can specifically use in patients with PAD, and it reduces the blood viscosity due to atherosclerosis. So these are, very similar things that we recommend for all patients with cardiac or cardiovascular disorders because they are certainly worsening the disease process here. And then prevent injury. So same teaching as diabetic patients when it comes to foot care. They need clean, moisturized feet to prevent drying and cracked skin. Break in new shoes over time. Don't overdo it. Always wear socks with shoes. Check their feet daily, etc. Furthermore, we have some nursing diagnoses here and breaking down interventions depending on those diagnoses. So in ineffective tissue perfusion, we want to promote arterial flow by putting them in the dependent position because remember when they're up, they're pale, so they're not getting that perfusion down to their feet. And then education about being compliant with their legs. They do have that acute pain, that intermittent claudication related to the ischemia and the atherosclerosis formation and the lactic acid buildup. So they need to avoid prolonged standing. That will make the blood stagnant and cause issues with thrombosis formation. Avoid crossing the legs at the knees. Crossing the legs at the knees, like this picture shows, can cut off the femoral or popliteal arteries and decrease the blood flow to the leg, furthering that ischemia and that pain that can develop from it. Report edema to their physician, and then take analgesics. That could be in the form of NSAIDs, or it may be, to treat that neuropathic pain, we need to do like a gabapentin or a Lyrica. They are at risk for impaired skin integrity related to the neuropathy that can develop and the edema that can develop. So teaching them not only about foot care, but that they are at risk for pressure development. So alternating rest and exercise is appropriate. And then they can have periods of activity intolerance. So we do teach that pain guides the activity. Do as much as it can tolerate without it becoming painful. And then in circumstances where the patient has developed bad wounds or ulcers, they're having pain at rest, or they've developed an infection like cellulitis, they need to not exercise. And that's basically because they could worsen anything that's going on. So if they're having pain at rest, there could be further complications or worsening of the disease that they need to get evaluated before they are up and exercising too much. Their cellulitis would just need to be treated. And we actually talk about cellulitis at the end of those PowerPoints. We'll go into that a little bit more. And if they have wound or ulcer development, then they just need guidance from a physician on how much they should be exercising so that they're not on those wounds or ulcers, depending on where they're at, and making those worse. So a lot of communication with their primary physician. If they need surgical management, that is an option, and there are different things that happen. Just like when you think about your coronary vessels, that are in your heart, you can do things. Okay, I think we're back. The internet shut off for a second. All right, let's get back into it here. So just like with your coronary vessels, where you can go in through cath lab and do angioplasty or stent, you can do the same thing in the legs. So angioplasty, balloon, or stenting to open up and allow the vessel to become patent. This is showing a picture here of the femoral artery. And so if we were needing to allow patency here, and you can see this yellow blockage that's developed within this artery, then a cath could be kind of fished through that area to do angioplasty or stent placement. Another thing that they can do, they can do thrombolytic therapy with TPA or streptokinase, just like they can for the coronary system, or they can do something called a fem-pop bypass. So this is where femoral popliteal bypass. They take a vessel from somewhere else in the body, and this was the same concept as a CABG, a coronary artery bypass graft, where they take a vessel from somewhere else that's nice and patent that can go without, and they bypass this area of atherosclerosis here so that perfusion can persist appropriately. If we were to have a fem-pop bypass or our surgical management of PAD, then preoperatively, we want to measure their baseline vital signs and monitor those throughout the procedure, document their peripheral pulses, and compare bilaterally, because we're going to monitor that before, during, and after the procedure. And then documenting whether those were palpable and whether they're 1+, 2+, or 3+, or whether they had to be Dopplered. Post-operatively, our goal is to prevent complications. So we're going to watch for risk for bleeding, which of course is a risk of any procedure. Assess their pulses. If their pulses start becoming weaker, or you're unable to palpate them when you were immediately post-op, but then you notice that they're getting weaker and then now they're absent, you can only Doppler them. Those are things you need to call the doctor for, because something may not be working correctly with the graft placement or the angioplasty or stent or whatever procedure they had. So they are at risk for developing ischemia again. And then monitor for edema formation. They are at risk for swelling and compartment syndrome after this procedure. How do we assess for compartment syndrome? If you remember, those are your 6 Ps. You have pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which is temperature changing to the environment. So that leg could develop pain that is not able to be treated adequately with medication when it once was. Now it's just like it's very intractable, hard to manage pain. Pulselessness makes sense. That's one of the last signs, but that's why you do assess those pulses. Pallor, paleness, because you have that decreased blood flow to the extremities. Paresthesias and paralysis, because you're not perfusing the nerves. And then again, poikilothermia, that leg will become cool to the touch and become cold like the surrounding environment. Now we're going to move on to Buerger's disease. Buerger's disease is an arterial disorder that is also known as thromboangiitis obliterans, which is a vaso-occlusive disorder of the small veins and arteries in your distal circulation, so in your fingers and toes especially. The cause is unknown, but there is a possible autoimmune cause related to it, and it is more common in men, especially smokers. So smoking, thinking about the nicotine and the vasoconstrictive properties of nicotine and smoking, can worsen this significantly. In Buerger's disease, we have severe pain and digital ulcerations that occur in the fingers and toes because of that severe vaso-occlusion, that vasoconstriction that occurs in those distal vessels that will completely stop blood flow to those areas. So they basically become necrotic and die and look purple and black like these pictures on the right here look. Cold makes it worse because in the cold we naturally vasoconstrict, so that can worsen this. The pain is described as that intermittent claudication in the feet, hands, or arms. Pulses are weak or absent because of that decreased blood flow and perfusion to the area, and then ulcerations and gangrene can occur. So they obviously need to be very aware of this and comply with their treatment regimen so that they don't lose fingers and toes. Nursing management of Buerger's disease is pain control, smoking cessation education, decreasing their exposure to the cold if they do have to go out in the cold, because obviously sometimes that's just inevitable. Then they need to be wearing thick, good socks, gloves, things to prevent extreme exposure or prolonged exposure to the cold. Calcium channel blockers are great drugs for any kind of vasospasm. We talked about nimodipine in patients who have hemorrhagic strokes when we talked about the neurosystem, which is a calcium channel blocker that prevents vasospasms. We give calcium channel blockers for patients who have prismatis angina because that's a vasospasm of the chest. And then we use it for Buerger's disease because there's a vasospasm in the fingers and toes that can be occurring. So that can really help relieve that, the occurrence of this disorder. If they do develop ulcers, then we need to educate and perform good wound care. Painful ulcers or gangrene may require amputation. And then what are important nursing diagnoses here? That would be ineffective tissue perfusion, which is kind of obvious based on the disease process here, and then risk for infection from the gangrene and necrosis of the fingers and toes. Raynaud's syndrome is very similar to Buerger's disease, but it presents in a different and more unique way. So similar to Buerger's disease, it is constriction and vasospasm in the small arteries and arterioles of the fingers, hands, and feet and toes. And some of the same causes may be induced by cold, nicotine, caffeine, stress, and it's also associated with other autoimmune diseases like lupus, scleroderma, or rheumatoid arthritis. Our difference here is in how the disease presents itself. So in Raynaud's, it is a specific triphasic or three-phase presentation. So first of all, there are spasms of the arteries, which are your vessels that go away from the heart, perfuse the rest of the body. So spasms of the arteries that lead to pallor, which is the top left picture here. So they have a decreased blood flow, they're going to get white. Then we have hypoxia that leads to cyanosis. Because of that decreased perfusion, not only did they turn white, but they're becoming cyanotic because of the decreased oxygen to that area. Then when the spasms stop and blood flow returns to the area, there's a sharp rubor or redness that occurs, this hyperemia, as the blood rushes back into those vessels. This can be painful as there are vasospasms and that blood flow is sharply stopped and then re-perfusing. Similar treatment strategies as Buerger's disease. We're going to keep hands warm and dry, avoid exposure to the cold, stop smoking, and then calcium channel blockers again to decrease those spasms and increase arterial flow. Less likely with Raynaud's to ever develop ulcerations or gangrene or anything like that. That's very characteristic of Buerger's. Raynaud's is your triphasic presentation of symptoms here. Okay, now we're going to talk about aneurysms. And when we talk about aneurysms, we have it can get a little confusing, but I'm going to make it clear. So just kind of keep up here for a second. An aneurysm is a dilation, stretching, or ballooning of an artery, just like these pictures show. They're called different things based on their shape. So this one is a saccular aneurysm. We have a fusiform aneurysm since it's located at the bifurcation of this artery here. And then we have a pseudoaneurysm, which is a kind of it's not, you don't need to know the difference. Don't even worry about that. You do not need to know the different types of aneurysm. We're going to talk about them in a very generic way. The big thing that you need to know about the aneurysm is that there is danger in rupturing of that artery. So when there is that ballooning or stretching of this area to form an aneurysm, that part of the vessel wall can become very weak. So with increased blood pressure, blood flow, trauma, things like that, that can further put force and pressure on that area. They become at high risk for that aneurysm rupturing. And then obviously arteries, this is where aneurysms are occurring in arteries and our high pressure vessels that are carrying blood away from the heart. If a aneurysm ruptured, we're at a very, very, very high risk of bleeding. We talked about aneurysms and hemorrhagic stroke, how that can be a cause of hemorrhagic stroke in patients that haven't experienced trauma, is that they have an aneurysm within their brain vessels and they rupture and can cause a hemorrhagic stroke. Here, though, we're going to talk about aneurysms within the aorta, which is the major artery that's delivering blood to the rest of the body from the heart. The most common cause of aneurysms is atherosclerosis and hypertension. Here we're going to talk about abdominal aortic aneurysms. They're located lower. They can occur at the arch or along the entire length of this aorta here, but the most common area is within the abdomen. It is often asymptomatic. If there are symptoms, you can see, like when a patient lays down, that they'll have this pulsating abdominal mass that occurs as blood is rushing through that part of the aorta. They may have pain at the groin, abdomen, or flank area. So you think about the aorta almost runs retroperitoneally, so that's why it's more towards the groin or back. And if you were to listen to the aorta with your stethoscope, if you were to put that over their abdomen and listen, you could hear a bruit because of that turbulent blood flow passing through. So again, our biggest concern with an aortic aneurysm is rupture and bleeding. We're looking at here an aortic aneurysm that's higher than the abdomen, which we just talked about. Oh goodness, here we go. What a mess, you guys. The internet sucks here right now. All right, let's get back to aneurysms. Ugh. Okay. So again, wherever the aneurysm is located within the aorta, whether it's up higher in the thoracic cavity like it is in this slide, or whether it's in the abdomen like we talked about in the previous slide, our biggest concern and worry is rupture and bleeding to death. If the aneurysm is located up higher in the thoracic cavity, then chest pain radiating to the back in between the shoulder blades, or if it's abdomen pain that radiates to the back and flank pain, then we're highly concerned about this. The patients will describe this pain as tearing. Almost any patient I've seen that comes in with this and they have a rupture, first of all, almost all of them have died, but they have that tearing quality. They're just very anxious, diaphoretic, they're in a state of shock, and they just say that their chest is tearing apart. They have expanding abdominal girth as they are bleeding out into it. And your shock symptoms, remember, those are things like tachycardia, tachypnea, decreased blood pressure. So you need to get IVs into these people quickly and try to support them with blood products. Although your ultimate goal here is to repair the aorta. It is your biggest vessel in your body. So if it's bleeding out, you have a very short time to get them to the OR and fix this. They'll have associated shortness of breath and hoarseness, decreased perfusion to the bilateral lower extremities. Again, the aorta is what perfuses your lower body, so you're not going to have blood flow to the lower extremities. We can see opposite blood pressures and different extremities because of that altered perfusion to all of those areas. Your left may be greater than your right, or vice versa if you're taking blood pressures in the arms, and that totally depends on where that rupture is, at what part of the aorta. And a ruptured aortic aneurysm results in a 90% mortality, so it's very, very, very high risk for death. Diagnostic studies that we can do if we're highly suspicious of a patient having an aneurysm injury or aneurysm rupture, is a chest x-ray. And that's what's shown here in this picture is that widened mediastinum. Normally that area should be much thinner, but you can see the deeper white is the heart, and this lighter white or this like gray area is where the aorta has aneurysmed out and is at risk for rupture if it hasn't ruptured already. CT scan, we can use their IV and insert contrast dye, which will flow through the aorta and show us and highlight any aneurysms or anything that might be going on. MRI can be done, although those take longer. So if it's truly an emergent aortic aneurysm injury or issue, then we're not going to do the MRI. It just takes too long. And then an ultrasound machine can also see if there's bleeding or it's quicker, user dependent, but it is a quicker bedside tool that we can use. To repair an aortic aneurysm, there are two different approaches. There's the open surgical repair, and then there's the endovascular aneurysm repair, which is a lot more minimally invasive. So with the open surgical repair, we're doing a large abdominal incision from the xiphoid process down to the suprapubic area, opening up their abdomen to access the aorta. They do a clamp before and after the area of rupture, and then they'll put this graft, just like this picture shows, in place of where the aneurysm was, and then sew that vessel wall back up. Major complications are associated with this. This is a very major surgery. Because of that clamp time, there is decreased perfusion beyond those clamped areas. So the longer that area is clamped, the higher risk they are for complications like myocardial infarction, embolus formation, renal failure, paraplegia from spinal cord ischemia. So if you're not perfusing the spinal cord, so patients can wake up and have paralysis to below their waist, or a stroke can develop. So when you're getting a report on these patients, it is important to know what the clamp time was, so you can tell their risk for ischemia, clot, AKI, etc. A clamp time of longer than 45 minutes is associated with pretty major complications. In the endovascular repair, this is again a much more minimally invasive procedure. If they're a candidate for this, then this is ideal. It's performed in the cath lab or in the interventional radiology suite versus the operating room. They can insert grafts in multiple sections, so that's a benefit here. But in order to be a candidate for this procedure, you have to have adequate iliofemoral vessels. So we are going to be accessing to get up to that aneurysm through the ilio or femoral arteries.